Everyone, it is my great pleasure and privilege to welcome you all to this much anticipated session, a truly novel and very new transformative area in diabetes, that is inhaled insulin. So as we all know, diabetes management has witnessed remarkable advancements over past few years, that is from human insulin to analog insulin and cutting edge delivery systems. And now we have a new therapy, but that was surrounded by a lot of questions and skepticism. So I hope with today's session that air will be cleared, and I request Rajalekshmi ma'am to kindly invite the speaker.
Good evening, everybody. I think Dr. Unnikrishnan doesn't need any introduction to this audience. I invite sir to deliver the regarding the new molecule, which is going to be a more promising drug to the diabetic patients who are on subcutaneous insulins. Okay, over to sir.
Thank you, Chairpersons, and it's a pleasure to be at this meeting. And I'm going to talk to you about a new treatment, which is inhaled insulin. Now, it is going to come to India soon, and we are all going to be using it. Now, my task here is to look at it as an independent commentator and to discuss the evidence before the molecule is actually available. So these are my disclosures, and I'm going to talk about the beginnings of insulin, the beginnings of inhaled insulin, the evidence of inhaled insulin, and then conclude. So insulin has been a century-old wonder. We've gone from animal insulins to human insulins to analog. We've gone from basal insulins to prandial insulins. We've gone from reusable pens, disposable pens, dial-up pens and pumps. But what is common to all these? What is common to all these is that you still need to inject insulin, and insulin is now still an injectable agent. But what is now changing is that there's been a long story behind it, and there has been a process of scientists over the decades trying to make alternative deliveries of insulin possible. And that long story, let me cut it short by saying that just this year, Cipla has received approval for distribution and marketing of Afrezza or Technosphere insulin in India. So it is approved now, it is going to be available, and once it is available, we'll have to learn how to use it best, and that is the purpose of this lecture. So what is Afrezza? It is a rapid acting insulin, and it also is to be advised only for adult patients. It was approved in the US as early as 11 years ago, and it is formulated using a Technosphere insulin technology. So it has insulin adsorbed onto another particle, and that particle is called FDKP, or fumarate diketopiperazine, and of course polysorbate 80. It's a very compact inhaler. In fact, I have the device with me. Let me see. So this is a device, it's a very compact inhaler. Inside that you have pre-filled single-use cartridges of several strengths, and it is a breath-powered oral inhalation. So you don't have to inhale through your nose. Your patients can inhale it through their mouth. So the particle is called Technosphere, and the actual name for Afrezza is Technosphere insulin, because you have these very tiny 1 micron particles, and these 1 micron particles in water are adsorbed onto the regular human insulin, and when the pH is below 6, this insulin gets stuck to the Technosphere. But when your patient inhales it, the pH goes to above 6, that's a physiological pH. The inhaled particles dissolve rapidly, separate. The FDKP and insulin are both quickly absorbed through the lung membrane. It goes into the blood, it gives your rapid acting insulin spike. FDKP is a metabolically inert substance. It is not metabolized, it is excreted in the urine. Histological studies have not shown it to be bound to tissues anywhere, so it just comes in and goes out by itself. So that brings us to what is the evidence. All this is good, but does it really work? And this is the data. I'd like you to look at the bottom panel, which compares the the purple color, which is Lispro, versus the orange color, which is Afrezza, you will note immediately two things. The Afrezza spike is earlier, and then there is a dip, and that spike and dip is also associated with a better glucose control. As you can see, the similar glucose infusion rate that is required will give you the earlier glucose control and then later on. And this is also reflected in real life, because if you see, it acts very fast. In fact, it acts within 12 minutes and it peaks within 45 minutes, which is little earlier than the other insulins, and it also comes back to baseline well below 181 minutes. So it comes back to baseline within 3 hours. So it is able to mimic the physiological insulin in a good way. So what is the evidence in type 2 diabetes? This is the study of technosphere insulin, or TI, in type 2 diabetes, and they studied 353 patients, uncontrolled type 2 diabetes, on more than one oral drugs, and they were randomized into either technosphere insulin or placebo for 6 months. So this was a 6-month study, and you see the HbA1c reduction of 0.82 versus 0.42, which is expected because you are comparing an insulin over placebo. But you see a good A1C reduction, and that A1C reduction is because of, you can see, the postprandial excursions coming down significantly. So better postprandial control, and you will also see that there is more hypoglycemia compared to placebo, and that's also expected, because if you compare insulin to placebo, you are going to get more hypoglycemia, but you can see the overall levels are quite comparable to other insulins and manageable. So this is a study of Afrezza or technosphere insulin in type 2 diabetes, where it was compared to placebo. A better model is type 1 diabetes, and a better comparison is aspart. So you can see that this is a study of type 1 diabetes. And why do I say type 1 diabetes is better? Because type 1 diabetes is not complicated by factors such as obesity and dyslipidemia and insulin resistance and so on and so forth. So you can distill the action of insulin on its own. And what you will see is that this is again a study of 518 type 1 diabetes people randomized into technosphere insulin or placebo, and this study was, technosphere insulin or aspart, and this study was for 6 months. And what it shows is that these skyscrapers look different, but they are really not that different. From 7.94 there is a 0.19 reduction, and if you look at the aspart, from 7.92 there is a 0.4. This difference between 0.94 and 0.4, this small difference is well within the non-inferiority cutoff, suggesting that if you take Afrezza insulin or technosphere insulin versus aspart in type 1 diabetes, these two insulins are comparable, not inferior to each other. But what is remarkable, what is interesting is that when you compare technosphere insulin to aspart, you will get lesser hypoglycemia. You can see these blue skyscrapers are shorter. Whether it is hypoglycemia or severe hypoglycemia, hypoglycemia is lesser, and probably that is because the insulin, technosphere insulin, doesn't hang around in the system as long as aspart to produce hypoglycemia. It comes in and comes out controlling the glucose spikes. It has to be taken with meals, and it is a prandial insulin, so that's very important to remember. So what are the side effects? If you look at the placebo versus technosphere insulin, you see the placebo is also a powder, and the side effect is cough. You see cough in about 25, 1/4 of the patients, and 1/5 of the patients on placebo, because you are inhaling a powder, and then of course there are other things like a throat pain and so on and so forth. And if you look at cough, you will see that 94% of cough were either a single episode or intermittent. And cough was there early in about 10%. It comes down very quickly. And only 2.8, clinical trials have shown that only 2.8, that is 1 in about 33 or 34 patients, are going to stop the inhaled insulin because of cough. So cough, something to watch out for, but not something that is likely to result in any discontinuation. Now we go on to another part, which is the change in lung function, which is, I think, very important to note. And you will see that if you look at technosphere insulin versus placebo, you will see that there is a dip in the FEV1, the forced expiratory volume 1, and there is a change, and this change may be very minor. You can take it as 130 ml or so, but there is a definite change that happens. But what happens if you stop the drug? If you stop the drug, the reduction in FEV1 returns to baseline. So it is resolved in 4 weeks after discontinuation. But if you look at this graph, it's going down, and will it go down and down and down like that with time? The answer is no, it will not. It will stabilize. As you can see, this is in non-diabetes people. This is in usual care, and this is with technosphere insulin. Yes, compared to other people, there is a slight decrease in FEV1, and that continues and that remains static. It is non-progressive, and it stays like that throughout the time, probably because of the effect of this powder on the lung. And it's important to remember that 1 out of 3, if you just look at the tallest skyscrapers in this picture, 1 out of 3 individuals will have a small FEV1 decline of 0 to 5%. If you see a more than 20% decline, you are supposed to stop the drug. Let's go to the basics of this device, and this is how the cartridge looks like. You can administer it at the beginning of the meal. Now, if you are giving this prandial insulin to a person who has never taken insulin, who's never taken prandial insulin, you start with 4 units with each meal. But if you look at people who are already on mealtime insulin, let's assume your patient is on 8 Lispro with breakfast, 12 Lispro with lunch, and 20 Lispro with dinner. So 8 Lispro with breakfast will be covered by the green cartridge. 12, the patient will have to take a 4 and an 8 together, and 20, the patient will have to take a 12 and an 8 together. So you can adjust it depending on the requirement. But remember, it's inhaled, so you can give it as a supplemental insulin even for a snack. So patient doesn't have to bother about when they will take the insulin. Occasionally, if they want to have an extra snack at 5 p.m., they can still take an insulin along with that. So these are the steps to use Afrezza, and you'll see that you have to open the package. Once you open the package, you can push the cartridge, and once you push the cartridge, you can load it, inhale, and remove. Well, I have it with me. Let me see if I can show it to you. This is a very small sort of cartridge, which the device inside this is a cartridge which the patient can use. You'll see it in a subsequent video which is coming up. So which patient is suitable for inhaled insulin? Remember, inhaled insulin is going to be a big deal because it's the first time in India that we have some insulin that doesn't have to be given by injection. So we have to know in whom we should use it, in whom we should not use it. Number 1, don't use it in children. It's not approved below the age of 18 years. Second, if there is chronic lung disease such as asthma or COPD, there is a risk of bronchospasm, and there is also, a risk of acute bronchospasm. So don't use it in those patients. During episodes of hypoglycemia, obviously nobody is going to give insulin. And of course, if there is any reaction or allergy, you should not use it. But 2 important things are children and adolescents, we should not be using it, and people with pre-existing chronic lung disease or even acute lung disease. For example, somebody has an acute pneumonia, is hospitalized for a lower respiratory infection, you may have to pause it. But all other cases, you can consider it's a rapid-acting inhaled insulin. Probably the pharmacokinetics are a little better than even the rapid-acting insulins that we have. You can use it in type 1 diabetes with a long-acting insulin. It's also, the India label says it can be used in diabetes mellitus in adults. So the India label presumably allows type 2 diabetes or type 1 diabetes or other forms of diabetes. It should not be used for decay treatment. That's important to remember. And remember, don't use it in smokers because their lungs are already putting people at risk, and on top of that, this powder is not going to do any good. So, things to remember before starting Afrezza: we should do an FEV1 and look for potential lung diseases. It should be more than 70% of predicted value. Do the FEV1 at baseline after 6 months, then every year, even if there are no symptoms. And if it falls to below 20% from baseline, it's important to withdraw the drug. The drug can be stored, if you can store it in the whole thing, you can store it in the refrigerator as a blister pack till the shelf life is over. If you open it and store it in the fridge, you can store it for about a month. If you're taking it outside, you open the cartridge, you have to store it for, you have to use it in 3 days time. But if you're keeping it outside as a blister pack, you can keep it for 10 days. So, all this is written, you don't have to memorize it, it's written in the instructions. So friends, it is the only inhaled insulin approved for type 1 and type 2 diabetes in adults as of now. In children, of course, nothing is approved. It's like an ultra rapid mealtime insulin. It's a very compact, small device. You'll also see that it's good for prandial glucose management. It is safe and effective in trials and up to 2 years, and hypoglycemia, cough, throat pain, and it has been approved by the Indian regulators, and that's good news for people with diabetes. Sorry, I'm just going to play a video, and after that we can have any questions because I think I have 4 minutes left.
Those are the instructions to properly inhale Afrezza, which will look like this. I'll break the inhalation down into 4 steps and walk through each one in detail. Step 1, select the cartridge. Because Afrezza enters the bloodstream in less than a minute and starts controlling blood sugar in about 12 minutes, you'll take Afrezza right before you begin eating. Once you open one of the foil packages, you'll find 2 blister cards perforated to tear off into small strips of 3 insulin cartridges. You'll first get your cartridge out of the strip by pushing the rounded plastic so that the cartridge breaks through the foil. Check the color and number on your foil strip or cartridges to ensure the correct dosage is selected. Step 2, load the cartridge. After taking the inhaler out of its plastic wrapper, you'll notice that there are 2 parts of the inhaler. This will open the inhaler. You should see or feel a cavity inside, which is where you may feel or hear a snap. That snap was the insulin cup sliding into position, becoming like a salt shaker. It's important that after this step,
Let me just try to play that last bit back again. But I think that was pretty much it, and we can take some questions if they are there. Can you play that last slide back? You can mute the sound. Oh, just a minute. So you can just put it in the mouth and inhale it. And once you've inhaled, that's it. It's very simple. You can just open it and remove the cartridge and throw it away. So very simple. You select your load, you inhale and you remove it. And then you can, depending on the number of cartridges you use, you can just open and just remove the cartridge like that. And depending on your dose, you can just calculate. Cost, we don't know the cost yet. Dr. Banshi, I think you had a question on the cost. We don't know the cost yet.
Can it be
But I think end of my presentation is open for questions.
Can it be used in GDM? And if not, why? What prevents it from being used in GDM?
No trials in GDM, and probably better not to use it. But there's no other reason why you should not use it. But no trials and no evidence. Better not to use it in GDM.
The ratio of short-acting insulin, if the patient is taking, is 1:1 or is it different?
This is a pure short-acting insulin.
That's what. So suppose the patient is taking short-acting actrapid or something, is it equal to 1:1?
Yes, it is 1:1, but now there are some new studies saying that the ratio may be actually 1.2:1. That means if there is 4 units of actrapid, 4 or 5 units of actrapid or human regular insulin, you may have to take 1 unit extra. You may have to give 6 units of technosphere because it is not exactly 1:1. The ratio is now, newer studies are analyzing that the ratio may be closer to 1.2. So if you are giving 4 units, you may have to give 6 units or so. 5 units, but you don't have 5 units cartridge, you may have to give 6 units.
So whether we have to replace with the subcutaneous insulin, or we can give it along with reducing the dose of subcutaneous insulin and we can give this one, or you have to stop the subcutaneous insulin and calculate the dose according to that, then we have to give inhaled insulin.
We can stop the subcutaneous insulin exactly, supposing patient is say on 888 of regular insulin 3 times, or Aspart or Lispro, we can give 888 of this.
Okay.
And then you can increase or decrease as needed. No need to again stop everything and then see. But if some patient has never taken prandial insulin, the starting dose is 444.
Same way, bolus it.
444.
Okay. So whether it is affordable for Indian population.
Sorry ma'am?
Whether it is affordable for Indian population.
We have to see the price. My bet is it's going to be little premium pricing. So your question, please use the mic.
Sir, you said it should not be used in children and adolescents below 18 years. But then it may not be very useful in type 1 diabetes, sir. Mostly type 1 diabetic children.
Well, we have to live with that. It cannot be used means it cannot be used, because you are exposing a powder and an insulin to a growing child's lungs, which has not been tested in trials. So we can't use it means we can't use it. So we'll have to use it in type 1 adults and in type 2.
Thank you. Thank you.
As we are running short of time, I think we'll close the section. And thank you, sir.
Thank you, ma'am. Thank you, everybody.
Talk.
Thank you, dear speaker and chairperson.